This is Melanie Rudd, the founder of She Overcomes. She Overcomes educates and equips women to overcome the imposter syndrome while biohacking the cyclical planning, goal syncing, and lived experiences of the rhythms of our lives through our Becoming Bold Leaders 8-week training, as well as our goal syncing 4-week program. We help women optimize time, energy, creativity, and focus in business and in life. This is a recording from Metamorphosis, the She Overcomes Women's Conference. I hope you enjoy this podcast.
Well, besides dedicating the last 20 years of my professional career in women's health, I am also a wife and a mom, and I'm currently trying to figure out how to launch from the nest 3 near adults. So if anyone here has some advice on that, maybe we could connect after this. But truly, without their support, I wouldn't be able to do things like this. So I am appreciative of them. So I am truly honored to be here today, actually. It is my pleasure to speak on a topic that impacts every single woman, every woman. If you're born female, you'll go through hormonal changes of perimenopause and menopause. And you might not realize that these changes start impacting us earlier than you might think. You're about to find out here as we go along. And it's important to be proactive to prevent some detrimental health effects on down the road. So as we go along today, I might skip through some things rather quickly, and I want to leave a little time at the end for you to ask questions. So if you want to snap a photo of the slide in order to jog your memory at the end of something to ask, please do that. Because if you're like me and you have brain fog, you need something to jog your memory for sure. So moving along here, welcome to Not Your Mother's Menopause. And you might be asking yourself why I chose that title. And I feel like in my practice, when I ask the patients that come and see me about their mom's menopause journey, about their mom's reproductive health, I get a lot of, I don't know, we don't really talk about that stuff. She never mentioned anything about menopause. I don't know how old she was when she went through menopause. And so we just didn't talk about that. And I want to change that narrative. I want us to talk about it. I want you to talk about it with your friends, with your mom. You can still go back and try to extract information out of her. And certainly with your daughters, so that we can get some collaborative going in terms of just knowledge and empowerment. So today my goal would be to open up dialogue about perimenopause and menopause, and also to empower you to make decisions, to be your own best advocate in terms of seeking solutions, because you don't realize this, but the choices you make around perimenopause impact your health for your entire life. And I'm not trying to get too deep with this here. We want to keep it light, so we're just going to continue on here. So Mindy is an actual patient. That's not her actual name. But in her early 40s, she started to experience crippling anxiety, heavy and irregular periods, insomnia, fatigue, random dizziness, palpitations, night sweats, and joint aches and headaches. There's a lot to unpack here with Mindy, right? Like, she could have a number of medical problems. And in fact, she went in a few times to seek treatment for her concerns. And you know, the lab work, gosh, it always turns out normal. It's always normal. There's nothing wrong with you. She was eventually worked up for anemia due to her heavy periods. And once that was corrected, she still felt crappy. She went back in and, was told again, or basically dismissed. And that happens a lot in perimenopause, because we just don't recognize all the symptoms that go along with it, but also if your lab tests are normal, your thyroid's normal, you're probably doing okay, right? So we're going to come back to Mindy as we go along here. Could Mindy be going through perimenopause in her early 40s? What is menopause anyway? I mean, it's technically when you have reached an age that your ovaries no longer produce your sex hormones of estrogen and progesterone, and also testosterone. It's your final menstrual period. You're done with your childbearing years. You can no longer have children. And in the US, it's a average age of 51. Now, certain things affect the age of menopause. If you've had a hysterectomy and you still have your ovaries, you'll go into menopause about 4 years earlier. If you smoke, about 2 years earlier. If you have autoimmune disease, earlier menopause. And the important part of that, of knowing that, is you have this time in your life called peri-menopause, which is those years leading up to menopause, and that can actually start in your late 30s or early 40s, where you're noticing some of these maybe subtle symptoms. So you'll hear other terminology related to the menopause transition, like I'm premenopausal. Well, that just means anything from, birth to menopause, so not really a super great term to use. You'll hear people say, like, I'm going through my midlife, or I'm going through the change. All appropriate. Or as I like to say, I'm in the hot phase of my life, which hopefully I don't hit the hot phase today up here. So menopause has been compared to puberty. So you all remember back when you were a teenager and your ovaries were just ramping up to prepare for potential, childbearing years. You remember those crazy ups and downs in the hormones? That's kind of what menopause is, or perimenopause, except for your ovaries are now winding down. They're kind of taking the opposite direction. But you still get these crazy ups and downs, and you still kind of revert back to that teenage brain. And there's all kinds of memes on the internet about menopause, which are absolutely hilarious. So if you're having a day with your menopause symptoms, you can always find something out there that can make you laugh about it, for sure. So what are these symptoms? And there is so many. There's no way I'm going to be able to touch on every single symptom of perimenopause or menopause today. And in fact, in my practice, I learn new symptoms from women every single day that they're suffering from menopause with. So the hallmark symptoms are irregular periods, vasomotor symptoms, so that VMS, that's night sweats and hot flashes. Those two together affect up to 80% of women menopause transition. And then commonly we'll also hear about vaginal dryness, pain with sex, low libido or low sex drive. You can even have frequent urinary tract infections, frequent vaginal infections, urinary incontinence, urge incontinence, all related to menopause. And those symptoms kind of get all the press, right? Because that's what healthcare providers learned about in school, that menopause is these kind of typical things. But what you might not know about is that there's this other list of symptoms. And in my practice, I feel like the most common thing women tell me is, about 3 years ago, I started waking up at night at 2 a.m. and I cannot fall back asleep. And it's sleep disturbance, like insomnia, to a crazy extent, to where, then that's causing you to feel fatigued the next day. And your mood is even worse. Despite having these hormone changes, now you add in lack of sleep. And then there is weight redistribution. So here's the second most common thing I hear from women that come into my office. They'll say, I exercise the same as I always have. I'm eating a healthy diet. Sometimes I have a beer here and there. And despite all that, I'm gaining weight, and it's coming around my middle. And despite all of that, yes, you're correct. If you change nothing as you start to approach perimenopause, you will, in fact, gain weight, and it will be around your midsection. And that is for a couple different reasons, which we'll get into as we continue on today. But kind of the theme of that is, you will have to make some changes. You can no longer get by with what you did when you were 25. It just doesn't work that way anymore. Some things that you don't hear as much about: bone density loss, osteoporosis. Brain fog is a huge one. People will say, like, I just can't concentrate. I feel like I have adult onset ADHD. Today, more women in their 40s and 50s are being diagnosed with adult onset ADHD than ever. And so maybe we need to reevaluate that. If you've always had those symptoms, then yeah, quite possibly you've just been undiagnosed. But if it's new onset for you, maybe it changes, and we can fix that with another approach. Here you see another list, or additional listing of symptoms that could happen. Basically, what you need to know is that there's estrogen receptors in pretty much every body system. So you could be experiencing symptoms literally from head to toe. I have literally had people tell me, my toes tingle in menopause, and when I started estrogen, they quit tingling. So it really could impact every aspect of your health. So that being said, don't assume every symptom that happens to you from age 35 to 55 is due to menopause. So women tend to go through menopause between the ages of 45 and 55, but you can have some symptoms, starting at age 35, and certainly you could have symptoms later too. But if you're 35 or 40 and you have new onset of heart palpitations, please do not assume it must be because your hormones are out of whack. That's a serious thing. You need to get that checked out. Maybe your fatigue is because you have sleep apnea, or maybe you do have a thyroid disorder. You are slightly more likely to be diagnosed with it as you age. So there are things that need to be medically checked out. We certainly don't want to be chasing an actual diagnosable medical condition with the idea that, hey, let's just have you do some exercise and get rid of your hormone symptoms. So some eye-opening statistics, and we're starting to see more dialogue about menopause and how it impacts every aspect of a woman's life. 30 million women in the US between the ages of 40 and 54 currently going through menopause, which means 6,000 women per day entering menopause, so final menstrual period and beyond. $15 billion, and probably actually more than that because this is a 2021 statistic, the global impact financially of women seeking care, purchasing products related to hormone health or menopause health. As you can imagine, this has a major impact on quality of life, work, relationships, the healthcare system, and lots of other places as well. So the Mayo Clinic says that activity losses due to hormonal symptoms of menopause, $1.8 billion annually. Like, that just blew my mind when I saw that. And only 15% of employers surveyed indicated they intend to have programs in place to support women going through menopause. And doesn't this just fit? Other countries do such a better job of, making women's health in the workplace a priority, like for maternity leave, for instance. The UK and Australia, so far ahead of us in terms of supporting women's health in the workplace. So if you're a leader in the room, take notes, jot some things down. How can I retain my employee who is in that age group of 40 to 54, who was a top performer and suddenly now seems to be struggling? Is there some support I can offer that person in terms of maybe even just offering them hope and giving them a place to come to? So other stats on menopause in the workplace, 80% of women identified menopause place challenge. Half of them considered making an employment change due to symptoms. Up to 40% of women surveyed reporting, this is crazy to me, reported missing a few days to a week of work per month for menopause or perimenopause symptoms. Well, just think about it. If you're one of these women that's going through menopause or perimenopause and you're having your period 70% of the days of the year, you might not want to go to work. And then, of course, there's a plethora of other reasons why you might feel like you would be not productive. 13% of women have quit their jobs due to menopause symptoms or perimenopause symptoms. And it's more commonly the younger women who decide to quit. So again, I'm picking on 40-year-olds. I'm much older than 40, so I feel like I can pick on people younger than me. A 40-year-old in the workplace, 40-year-old woman in the workplace, doesn't just have a job to worry about, right? She has kids, daycare, cost of diapers, cost of meals for her family. She has to get to work and leave work early to pick kids up from daycare. She has aging parents that now are kind of like having toddlers that she needs to deal with. There's so many pressures on a 40-year-old, and her scales are probably barely balanced. So if we tip her over the edge with a hormonal problem, she's, maybe likely to quit her job. Or maybe you're not someone who has children, and because you don't, your employer assumes, like, hey, you can stay late, or you can do more because you don't have kids, or your family thinks, Well, because you don't have children, you can take care of mom and dad. Same little unbalance occurs there. So lots of women choose not to go for a promotion, or just don't even try, or they get passed up for a promotion because they feel like they just don't have it in them anymore to perform like they have before. And only 31% of women feel comfortable discussing their menopause concerns at work, because you know what? If you talk about perimenopause, you reveal your age. And there's concerns of ageism and discrimination in that way. And this is regardless of the type of job a woman has. So white collar, blue collar, you're a nurse, you're a waitress, you work in a trucking company, all women report these statistics. So if you do the math, the average lifespan of a female in the US is 80. So if you start to have symptoms of perimenopause in your late 30s or early 40s, you're technically gonna live half of your life in menopause, half of your life. So, let's concentrate on making, the rest of your life basically the best of your life, right? So let's talk about, without going too deep into a science lesson, which hormones are impacted by the menopause transition. And these are ovarian hormones. So hormones produced by your ovaries, such as estrogen, progesterone, and testosterone. Now there is other hormones at play here, not produced by the ovaries: thyroid hormone, cortisol, insulin. And they come into play in terms of women's perimenopause and menopause and beyond as well. But mainly we're talking about those ovarian hormones. So up here on the upper left-hand side, that's a nice little graph of a normal menstrual cycle. This kind of shows the ebb and flow of estrogen and progesterone. I get this out for every patient I see in my clinic, and I point out to them that when you have this nice little graphic of a menstrual cycle in your 20s and 30s, it still caused you problems, right? In that second half of the menstrual cycle, the luteal phase, after estrogen peaks and then drops and you supposedly ovulate and then progesterone takes over, that's where the headaches came, the bloating, the irritability, the sleepless nights, the low energy. So we know hormones can impact how we feel. Think to your postpartum period if you've had children, or while you were breastfeeding and they say, your hormones are going crazy. We know they have a huge impact on women's health. And then contrary, down at the bottom, and that crazy flow of hormones, that's perimenopause. And that's years long, years of ups and downs. And so if you were to average it all out, then that's the graph on the right here, where in early perimenopause, you see more of a drastic reduction in progesterone with an overall reduction in estrogen as time goes on. So the next couple slides here, my intention was to explain, why do hormones cause psychological and physical symptoms, or why do changes in hormones cause these things? And I won't get into every one in detail, but the overall common factor is a decrease in estrogen, the main female hormone. As estrogen decreases, you get a lot of these symptoms. So most people, unless you're in healthcare, and even if you are in healthcare, you might not realize that your ovaries are actually controlled by your brain, by the hypothalamus and the pituitary. So if your brain is stressed from these crazy hormonal up and downs, you can imagine there's going to be some repercussions from that. So vasomotor symptoms, night sweats and hot flashes, because that's a very common symptom of perimenopause and menopause, kind of temperature regulation center is in the brain where the impact of low estrogen is felt. Mood swings, I feel like that's pretty self-explanatory. We've all experienced mood changes from hormonal changes. And again, this is just because our brain is impacted greatly by hormones. Skin. I have a lot of women tell me, I feel like I woke up one day and I just looked old. And beyond, the vanity of that, estrogen helps us produce collagen and elastin. So it makes sense that when levels of collagen and elastin decrease, which they also just start decreasing on their own from around age 30, But with the dramatic changes in estrogen, we see thinner skin, drier skin, more sensitive skin. So whatever you've been using on your face now causes you to have a rash. Yes, that happens. We see more wrinkles. Now, certainly wrinkles, can be affected by other things, lack of sunscreen, genetic changes, smoking, that type of thing. Vulvar skin, so the vulva becomes thin, dry, and that's where the painful sex comes in. So lots of skin changes, and you might not think of that. You might not think like, oh, it's maybe because of my hormone changes. Libido is sex drive. I'm just going to say one thing about sex drive and menopause. If you had a really healthy sex drive going into menopause and then it just dropped off a cliff, probably hormonal. If you never had a very good sex drive, or you kind of thought like sex was just for making kids and then you were kind of like over it, I don't know if hormones are really going to fix that for you. It's really multifactorial. Like, do you get enough sleep? That actually impacts sex drive. Do you get enough exercise? Do you have a good relationship with your significant other? It's not kind of a one and done with sex drive. We all know that changes in hormones can cause insomnia, joint and muscle pain, because again, that decreasing collagen production, and then just estrogen is anti-inflammatory. So as you slide down in that estrogen production, you have less anti-inflammatory process going on. Bone health, probably the biggest silent repercussion of menopause. In the immediate post-menopause phase, so say you quit getting your periods at age 51, your bone density takes a pretty deep dive in the next 2 years. And that is because of lack of estrogen. It's involved in kind of helping your bones maintain their density. So bone density, concerns are why grandma gets the hip fracture and then goes to the nursing home and never comes out. Or, if you want to think of it in a less serious way, it's why you start to shrink in height as time goes on, because your spine is basically compressing because your bones aren't dense anymore. Brain fog, pretty clear that estrogen and progesterone affect processes in the brain. And that, has something to do with, with mood changes too. Brain fog and mood change, mostly due to the fact that estrogen helps our happy chemicals like dopamine, norepinephrine, and serotonin act like they're supposed to. So what can be done to ease symptoms? It's like doom and gloom. It's not, I promise you. I generally say that there's 3 categories of ways that you can ease your perimenopause or menopause symptoms. And the number one thing you're going to say to yourself like, oh, I've heard this before, lifestyle management. And not in any order. Lifestyle would be first, of course. But the second thing, medications or modalities. So if you're not someone who wants to use hormones or you can't use hormones, you might consider other prescription medications or supplements or modalities. Like maybe your vagina is super dry and you want to try a hybrid fractionated laser to help restore and replenish that tissue. And then, of course, like if your skin is changing, we can help you with that too. And then the third thing would be hormone therapy. So we're going to take a look at all of those here. So lifestyle changes. I have this nice little acronym. I call it DAS, plus S, plus S. So diet, and by diet, I mean you don't go on a diet. I mean like what is your diet? What's your nutrition, basically? And you want to shoot for an anti-inflammatory diet that's high in protein. You've heard it. Limit your ultra-processed foods. It's just more important now in your late 30s and 40s and 50s to make these changes in diet. You could totally control probably most of your symptoms with diet change. And then activity. So remember I talked to you about how women gain weight in menopause? About 70% of women report gaining weight throughout the menopause transition. And it's actually statistically only 5 pounds. But there's this redistribution of weight to around the midsection. And that's the bad kind of fat, right? Like that's the kind of fat that increases your risk for type 2 diabetes, cardiovascular disease, and other inflammatory conditions. So why does that happen? Why is it that you've been doing the same things forever, and now all of a sudden you're gaining fat? Well, part of it is just what we've evolved. Like we just move less. We eat more processed foods. And overall, there's a 30% reduction in spontaneous physical activity in women who are in the perimenopause transition. So, you used to shop for your groceries now, or we mostly don't. You used to run after toddlers in the park. You just were more active. Now we maybe work out for 30 minutes before work, but then we sit for 10 hours a day, potentially. So you're kind of offsetting that. So 30% reduction in spontaneous physical activity, and then a 9% overall reduction in just basal metabolic calorie burn. So the main reason for that is not only due to decreased activity, but decreasing muscle mass. So since you were in your 30s, you've been losing muscle mass, unless you've been very intentional about keeping it. So you're lifting weights, you're lifting heavier weights, you're eating protein 150 grams a day, and most of us aren't. So you've been losing muscle since you were in your 30s. Muscle is metabolically active, and when you don't have as much muscle anymore, your metabolism decreases, simple as that. It's not that your thyroid isn't working, it's that you don't have as much muscle mass. So then sleep. I say if you could just get good sleep, cortisol levels would be happy, you'd function so much better the next day. Well, sleep, is just one of those, it's like a leprechaun. You just can't catch it. You can't make it good, right? Especially in perimenopause. So if you've done the sleep hygiene, you've ruled out sleep apnea, you've tried the magnesium supplements or maybe the melatonin, and you're still not getting sleep, it's really messing with you, so get help for that. Stress management. So again, this is like cognitive behavioral therapy. This is self-care at a level beyond taking a hot bubble bath. This is making your health a priority. You go to your annual exams, you have your mammograms, you intentionally exercise, you intentionally eat the strawberries instead of the Cheetos. This is self-care to a different level. And in your 40s and 50s, someday needs to be today. Because as you approach menopause, you have this sharp increase in risks like heart disease, diabetes, some cancers, that you can manage with changing your life today. I'm so glad that earlier today on the first floor, there was so much talk about how social connections impacts our health. And I didn't even know we were going to talk about that. I was like ecstatic when I heard that. I wanted to jump up on that stage and say, yes, people who have lack of social connection, because we're in an epidemic of loneliness, as you heard, die earlier. It's a fact. Also, people who do not strength train die earlier. And people who do not strength train or have social connections end up in a nursing home earlier. Maybe due to cognitive decline, or maybe just due to the fact that they can't get off the toilet anymore because they're too weak. They didn't do the work earlier in their life. So that's kind of heavy, but hey, I'm trying to motivate people to make some changes here. Other lifestyle things, limit alcohol. I feel like we all know that, right? So now there's absolutely no safe level of alcohol intake. It used to be, you've heard, like women can have one alcoholic beverage a day, and that's, everything in moderation, right? And hey, I'm all for that. I'm probably going to have some beverage tonight. But like the truth is, like there's no safe level. So any amount of alcohol increases your risk for a number of cancers. And certainly in perimenopause and beyond, it settles around your belly and increases your risk for weight gain. Caffeine. Anyone know the half-life of caffeine? Allie, you can't answer. 6 hours. So if you have a cup of coffee or a Diet Coke at 7 p.m., 6 hours later, half of that caffeine is still in your body. Now that varies a little bit by, person by person, but that's going to impact your sleep. If you could get by with that when you were 25, chances are you can't get by with it now. And alcohol is absolutely terrible for sleep, and it has been your whole life. It's just that when you were in your 20s, and alcohol affected the quality of your sleep, you got to sleep till noon the next day, so you made up for it. Not realistic anymore. Alcohol makes you drowsy and make you fall asleep easier, but it definitely interrupts your quality of sleep and probably causes you to wake up frequently, and then plus you're peeing all night, right? So that's a problem as well. Not a lot of concrete scientific evidence that specific supplements work for hormonal changes, but there is some evidence behind magnesium. You've probably already heard this. Magnesium L-threonate and magnesium glycinate. Sure, pick up a bottle, try the bottle, one at a time, before you go to sleep to see if it helps with your sleep and relaxation. If you finish that bottle and it hasn't worked for you, then I would say it's not going to work for you. And in the US, supplements are not regulated by the FDA, so you could be eating dirt or manure. So your best bet is to find one that's at least certified by like USP or Consumer Lab or NSF, because they at least have some seal of quality. So symptom tracking via app, like if you have the Apple Watch or the Fitbit or you have the Oura Ring, I mean, it's great insight into your cycles. Even if they're all over the place, it'll still give you some pretty good advice about just being aware of what's going on with your cycle or lack thereof, to be honest. We talked about behavioral therapy, and then let's talk about how hormone therapy how it can be helpful for women. A little reminder though, I think I pretty much emphasized this. If you don't make time for your wellness, you'll have to make time for illness. Definitely, I'm sure most of you have seen some of this. So, hormone therapy's kind of gotten a bad rap for the last 20 years in terms of how it can help women. And that is because of a landmark study, the results of which were released in 2002, so we're talking 23 years ago here, 20-some thousand women in this study. In 2002, this study changed the trajectory of caring for women in menopause because a report was released to the media about concerns of potential health risks from using hormone therapy, even though the study did not necessarily apply to women or all types of hormone therapy. So misconceptions from this landmark study persist today. It's why if you rush out of here and make an appointment with your family doctor tomorrow to discuss your perimenopause, they might say, nope, not touching you with a hormone, I'm just not doing it. So for 20 years, we haven't been teaching our medical students about how to deal with women in perimenopause. Our nursing students, our advanced practice providers, it's just not part of the curriculum because everyone is too scared to dive into hormone therapy. Since this time and in recent years, the Women's Health Initiative study there's been a deep dive into some of the misconceptions and some of the inaccuracies in it. So now we have a lot better evidence on the safety of hormone therapy. So there's a few different ways to get hormone therapy, and I would encourage you to seek out a provider who either is certified by the Menopause Society or at least follows Menopause Society guidelines, because we know that's the safest option for you in terms of getting hormone therapy. The very safest way to get hormone therapy in terms of estrogen is through a patch, a little patch that you peel off and stick onto your skin, low abdomen or upper buttocks. It can be on for a week, or there's a twice weekly patch if you'd rather do that, or it doesn't stick very well. And that is the safest way to get estrogen because the levels are very stable and steady, and also because you avoid this thing called the first pass effect. So estrogen absorbed through the skin does not go through your mouth, through your belly, and through the liver first. And by avoiding that first pass effect, you don't increase clotting factors. So we can mitigate, minimize, maybe even eliminate clotting factor increase with transdermal estrogen, which is one of those things that came out of the Women's Health Initiative study. And they said, well, no, it's too risky for some women to use estrogen because of the risk for blood clots. So now, and they did not use transdermal estrogen in that study. They used Prempro, pregnant mare urine, and Provera, so a very specific type of oral therapy. So you transvaginal estrogen, and you can get locally absorbed transvaginal estrogen. So this is for women who have, real issues with vaginal atrophy, dryness, pain with intercourse. Vaginal estrogen is only absorbed in the vagina and vulva. So if you're someone who can't use hormones or you prefer not to, you can still use a little estrogen in the vagina and vulva and get a lot of benefit from it without it increasing systemic absorption. And sometimes you might have to use systemic estrogen and vaginal estrogen because systemic doesn't always reach the vagina very well. There is also a transvaginal estrogen option that is absorbed systemically. It's a ring, you can leave it in for 3 months, and it does relieve symptoms of menopause throughout the body, in addition to the vagina. There's still oral formulations of bioidentical. I'm doing the bioidentical quotes because nothing's bioidentical. We can't actually extract your estrogen and give it to me, even though I want that. Bioidentical is just a term that it's as close to your body as possible. So that's what the transdermal estrogen is. And then you can get it in an oral formulation and vaginal as well. Oral estrogen is pretty cheap. There is that slight increase clotting factors, so that's something to take into consideration. So I'm not a proponent of compounded hormones unless somebody can't tolerate a prescription version. And then the one exception is testosterone. You're going to hear a lot about how testosterone can benefit women going through the menopause transition. And we can't get that in a prescription option because that's only for men in the US. There's no FDA-approved option for women. But we can have that compounded, and we can monitor those levels carefully if you choose to use it. So that's one compound I'll advocate for. Many options covered by health insurance, but not compounds. Compounds are typically not covered by health insurance. And then if you've been away from estrogen for a long time, so you finally decided to seek treatment after feeling this way for 5 years, it's going to take a while for hormones to help you feel better. If you're just going through the menopause transition now and you're kind of early to the game for potentially using hormones, you might have relief a lot sooner. In clinical practice, I'm hearing women say that they get relief of sleep the quickest. Out of all the symptoms, they're feeling relief in sleep the quickest. So within 2 or 3 weeks. And then after that, it's, my night sweats are gone, my hot flashes are gone, my brain fog has been lifted. I'm definitely seeing a lot of positive benefits for sure. And there's no harm in trying hormones for 3 to 6 months. If they don't work well for you, you can just stop them. It's not a pellet you have to dig out of your backside. You just take the patch off and throw it away. And if you have a uterus, do know that you have to also use progesterone along with your estrogen to balance out things and keep the lining of your uterus healthy. But if you don't have a uterus, you can use just estrogen alone, and that's a really easy process. So I put this up here, like who's a candidate for hormone therapy? And I did write on the top of my list, if you're symptomatic, maybe you're a candidate for hormone therapy. So if you're having symptoms, that's true. But we're going to be seeing a lot of information now about the health benefits of using estrogen in the menopause transition for even non-symptomatic women. So we know that it's FDA approved for you to prevent bone density loss. And we're going to be seeing some research come out saying that it can prevent a spike in your cholesterol at the time of menopause. It can reduce your cardiovascular risk, reduce your type 2 diabetes risk. And lots of good benefits. But for now, you see people seeking it for symptomatic reasons. Whether you are or not, I'm happy to have a conversation with you about that. There is a magical window in terms of using hormone therapy. You want to use it within 10 years of your final menstrual period, or before age 60 is a rough guideline. After that point, using hormone therapy could increase your risks to where risks would outweigh the benefits. Increased risk of dementia, for one, if you start too late, and certainly increased risk for maybe some blood clots or stroke. So you want to be active. I don't want to give estrogen, especially not oral estrogen, to someone who's sedentary or unable to exercise. Again, clotting risk. And then a non-smoker, and then just overall you have to be healthy. So when you visit with me, about whether you're a candidate for using hormone therapy to ease your menopause transition or prevent some of these detrimental health effects, I have to take a deep dive into your health history and make sure it's safe for you to go forward with that. And that's what any provider would do for you. So the Menopause Society came out with a more recent recommendation on hormone therapy use, saying, you know what, benefits actually outweigh risks for most women when initiated younger than age 60 and within 10 years of menopause. So I feel like this is kind of the green light from a major medical society saying, hey, we recognize that after 20 years of ignoring women's health progress related to hormones, that this is probably the solution at this point. Some perspective, in 2002, prior to 2002, 43% of women used hormone therapy to help transition. Today, it's about 4 to 6%. And now we're finally seeing, like all these women that didn't use hormone therapy, we're seeing the health consequences of it. We're seeing, like, literally earlier death, increased cardiovascular, type 2 diabetes. You heard me say it over and over. So it's something to really look into. Back to Mindy. Well, as I would encourage you to do, Mindy did not give up on her journey. She kept going to people until she found a healthcare provider that would listen to her. And I'm sorry to say you might have to do that. You might have to just keep going to someone until you find someone who will listen. And hey, I'm not knocking any healthcare providers. I was a healthcare provider even just a few years ago who would probably, give you a look if you told me, like, I'm going through all these things. We just didn't know. We didn't know that all these symptoms were related to menopause. But now that we know, the word is getting out, so do not give up. Keep going until you find someone who will treat you. And I am happy to see you at any time. It's truly my passion to make sure that you can live the best life after menopause. So how can you find me? Well, after about 18 years of working in a traditional healthcare setting in women's health and OBGYN, I took a huge leap of faith. And I say leap of faith now looking back. At the time, I was super confident that this is the change I needed. But I took a leap of faith and decided to try something new. So now I am at Center for Plastic Surgery in South Fargo. And don't let the name scare you. We do lots of fabulous things with plastic surgery, and we have impactful results for people needing surgery. But we also have an entire team of talented professionals who, like myself, are passionate about helping people, men and women, look and feel good about themselves. And this is where you can schedule an appointment with me to talk about your menopause journey, and you will have my dedicated attention one-on-one. And I will help you come up with a plan that is perfectly made for you. And perfectly is a strong word. Hormone therapy is not one and done. There's probably some, adjustments required. And as we age and make less estrogen and have new health consequences, we make adjustments. But I'm super happy to do that for you. And then I also do aesthetics and lots of other fun things there. But if you schedule an appointment for hormone health, we're going to focus on that. We're really going to get to the bottom of how we can best help you. One other thing I want to say before we're done here. So you all have your phones out, so you don't have to, there's no homework. But so your phones have been listening to you, right? So you're going to get bombarded with stuff about peri-menopause and menopause and what to do about it. And hey, that's better than what I get bombarded after. Like a night out with friends, it's peanut butter whiskey and espresso martinis. My phone will tell me how to make them. But you're going to get bombarded. And I do want to just make one recommendation. I have no affiliation with this author at all. But if there's one book you want to read about perimenopause and menopause, or one website you want to go to, it's this gal, Dr. Mary Claire Haver. The New Menopause is her most recent book. She has a website, thepauselife.com. She has close to 300 past episodes, which you can go through and find your symptom on almost every one. I've vetted this book. I've read it front to back many times. I have little dog ears and places that I still refer to because people will come into me and say, I read in Mary Claire Haver's book on page 300 that you're supposed to do this. And indeed it's there. And she cites her sources, and it's legitimate scientific studies for the most part. And exciting news, because I love when there's attention brought to perimenopause and menopause. On ABC on Monday, on the TV, if anyone watches like real TV anymore, there's going to be a menopause or perimenopause special hosted by Oprah, which is great because there'll be a lot of attention, brought to the subject. Now, I am a little hesitant to announce that you should watch that because there is going to be some other celebrities on there, and sometimes they come up with some alternative approaches to treatment that might not be exactly what's recommended. But Dr. Mary Claire Haver is going to be a featured guest from what I understand, and so I feel like she will help them to keep it real. So with that, I'm happy to take a few questions if there is any. And keep in mind, if you have a question, someone else probably has the same one, so feel free to speak up. But if you don't feel free to speak up, grab me afterwards or catch me at happy hour, and I'm happy to have a side conversation.
Hi, is it on?
Yes.
Okay, thank you for your presentation. This was very informational. My question is actually in two parts and kind of in the same line. So I don't know if anyone else has heard this, but there's this big idea that beef organ hormones are really, really huge for women right now. I don't know, what is your take on that? And the second part of the question is in regards to thyroid issues. I don't know if anyone else in this room has any type of autoimmune disease, but that's something I deal with. So I'm curious, how that plays into premenopause or menopause.
Yeah. So beef organ hormones, as a solution, or as they impact our own hormonal journey. Okay. Sure. Yeah. I've actually. So I am happy to do some research into that, though. I tend to follow kind of standard medical guidelines, but I enjoy hearing, or I like to hear what other people are hearing about so that I can at least speak to whether it's something legitimate or not. So I'll definitely look into that. As you heard me say earlier, thyroid, along with other autoimmune conditions, can cause you to go into menopause earlier. The main impact that I would suggest is something that you should maybe pay attention to as time goes on is if you choose to use an oral hormone preparation at some point, like hormone replacement therapy orally, it can mess with your thyroid hormone levels a little bit. That's the main implication in terms of thyroid conditions and hormone replacement therapy use. Transdermal estrogen doesn't seem to play with the TSH at all, but oral estrogen does.
If you have medically induced menopause, like you're taking medications to prevent cancer reoccurrence, is there any, is it the same recommendation that's different? And do you have experience with that if somebody came in to visit with you and is going through that?
Yeah, so that's a really, really good question. So if you are a cancer survivor of hormone receptor positive breast cancer or other hormone receptor positive cancers, it is not recommended at this time that you should be using traditional estrogen and progesterone therapy. However, I think we are going to be seeing some therapies potentially come out that would help relieve symptoms, because obviously these women are still suffering, in the form of SERMs, selective estrogen receptor modulators, that could actually allow you to have some of that estrogen effect in your body, but protect your breasts and uterus, if you still have one, from the effects of estrogen. So right now, that's not universally accepted. You might be able to find someone who is, willing to, if you're really struggling, to prescribe that for you. I generally don't. You could use vaginal estrogen if you're really struggling with vaginal atrophy, because that is not going to be absorbed systemically to any great extent. But this is a perfect scenario of why we need more research in general into women's health. There's a book, Estrogen Matters, by an oncologist, about his theory on using estrogen, even in women who've had breast cancer. And he has a very personal reason behind writing that book. He's a very intelligent person. There's a great podcast out there actually with him and Heather Hirsch, MD, who's another kind of famous menopause warrior physician. And he suggests that we are going to get to a point where we can give estrogen to cancer survivors. And it's a great read. I've listened to it on audio. So you might find some resources there. Very good question.
Alrighty, I think that is actually our time. We have 32 seconds left, Tosha. Good job.
What else can you throw at me?
Give her a round of applause.
Thank you so much for joining us in our mission to remind women of who they are, how to professionalize their strengths, and step into their purpose. To learn more about She Overcomes and our Becoming Bold cohorts, you can go to sheovercomes.co. To learn more about our virtual community, the Ezer Collective, go to ezer.disco.co. And finally, to learn more about my book, Irreverent, a memoir of reckless hope, unexpected love, and finding my voice, you can find that at melaniemichelle.co/books. Until next time, Overcomer, it's time for you to find your purpose, chase it with courage, and step into your unique gifts. Thank you.